Welcome back to Ellie Scrubs In. This video is a practical, step-by-step walkthrough of the foundational suturing skills that show up everywhere. How needle angle controls eversion and inversion. How to place a simple interrupted stitch. How to bury a knot with an inverted dermal stitch. How to protect a corner with a corner stitch. How to control tension with a slip knot. And how to evert and support edges with a vertical mattress. We will review the fundamentals of wound approximation before moving on to live examples of different stitch patterns. If you are a medical student, new intern, or early learner in the operating room, this is the core set to drill until it feels automatic. Let's scrub in. Suture basics, eversion and inversion. First, we will review one of the highest yield fundamentals in suturing. Whether a wound edge ends up flat, everted, or inverted is not luck. It is geometry. The final edge position is determined by the angle the needle travels through the tissue relative to the tissue surface. That angle comes from two things the surgeon controls: how much the edge is lifted or everted with forceps, and how much the wrist rotates to follow the curve of the needle on the way in and on the way out. Think of the needle as a small, curved wheel. It should roll through the tissue along its arc. If it is pushed straight or dragged shallow, the edge position will be wrong. For even apposition, gently evert the edge by a moderate amount, then rotate the needle so it enters at about a right angle to the tissue plane. Do the same on exit, a smooth wrist rotation that brings the needle out at about 90 degrees. The result is what the animation shows here. The edges meet evenly, with neither edge being pushed up or pulled down. For eversion, increase both components. Lift the wound edge more, and rotate the needle more so the pass becomes steeper than 90 degrees. Repeat that same steeper roll on the way out. When the knot is tightened, those steeper bites intentionally tip the edges up. Eversion helps the wound edges heal and reduces scarring. When the suture is removed, the edges will lie flat and lead to better cosmesis. A very common mistake is inversion. That happens when the edge is not everted enough, or the needle is not rotated enough, so the pass becomes shallow on the way in and on the way out. Instead of rolling, the needle skims. Then, when the knot is tightened, the edges collapse inward and the closure looks sunken. Inverted wound edges have poor wound healing and suboptimal cosmesis. Inversion of wound edges should be avoided. Next concept: if the two wound edges are similar, the bites should be similar. Take bites of equal depth going in and coming out. That is what keeps both sides ending at the same level. If one side is shallow and the other side is deep, the deep bite side is pulled upward and the shallow bite side is pulled downward. The animation shows exactly that leveling error. The same mismatch in the opposite direction creates the same problem, just flipped. Unequal depth equals unequal edge height. Mismatched wound edges result in poor wound healing and excessive scarring. Now the useful twist. That effect can be used on purpose when one wound edge sits lower than the other. Take a deeper bite on the low side and a shallower bite on the high side. When the knot is tied, the low side is pulled up and the high side is pulled down, and the edges meet on the same plane. This leads to optimal tissue approximation and wound healing. Simple interrupted stitch. Now for the most important foundational closure, the simple interrupted stitch. This is the first stitch to master because it teaches needle angle, bite symmetry, and reliable knot tying. Set up with two tools only: a needle driver in the dominant hand and forceps in the other. Think of them like a knife and a fork. The driver does the work. The forceps gently controls the tissue edge. Load the needle securely, typically about 2/3 of the way from the tip toward the swage, so the needle follows its natural curve when it rotates through tissue. Evert the first wound edge with the forceps, then enter the skin at about 90 degrees. Drive the needle with a smooth wrist rotation, following the curve. The goal is to capture more depth at the base than at the surface, which helps create slight eversion and stronger dermal purchase. Now mirror that on the opposite side. Take a bite that matches the first one in distance from the edge and depth. Symmetry matters. Equal bites bring the edges together at the same level. Pull the suture through, leaving a short tail for tying. For the first throw, wrap twice for a surgeon's knot, so the knot does not slip while tension is set. Tighten just enough to approximate. Avoid strangulation. The tissue should come together, not pucker or blanch. Add the next throw in the opposite direction to begin a true square knot. Keep the hands low and flat as the knot is seated. Continue with additional alternating throws. Each throw should be deliberate, flat, and even on both strands. If the suture is monofilament, add extra throws for security. If the suture is braided, fewer throws may hold, but the rule remains the same. Alternate direction to keep the knot square. Trim the tails to an appropriate length. The finished stitch should show gentle eversion, the knot sitting to one side of the incision line, and clean edge alignment. Next, this same needle angle and bite symmetry will be applied to buried dermal stitches and other tension managing patterns. Next up is the buried knot dermal stitch, also called an inverted simple interrupted. The goal is simple: close a deep wound and bring the dermis together while keeping the knot down at the base of the wound. Start on the first side at the deepest part of the wound. Take a bite that begins down in the deep dermis and then drive the needle up, exiting in the subcuticular plane, just under the skin surface. This deep to superficial pass is what sets up the knot to bury. Now move to the opposite edge and mirror the depth in the opposite direction. Enter at the subcuticular plane and drive the needle down to exit at the base of the wound. This superficial to deep pass is the second half of the inversion. Here is the critical checkpoint. Before tying, both strands need to be oriented on the same side of the stitch. If one strand is superficial and the other is deep, the knot will migrate upward and sit where it does not belong. Tie with an instrument tie. The first throw is wrapped twice to create a surgeon's knot that holds tension. When cinching down, pull the strands in the direction of the wound, not straight up. Pulling parallel approximates the edges and helps the knot flip down into the depth. Secure the knot with additional alternating throws to lock it. The wound edges should come together smoothly without strangulation, and the closure should look inverted at the dermal level. Now trim the tails. The key visual takeaway is that the knot ends up at the bottom of the wound, buried under the surface, leaving a clean top layer that is ready for additional deep dermals or a subcuticular run. Slip knot. The slip knot is a tension control knot that lets the stitch slide while you dial in the exact amount of approximation you want. It is used for skin and delicate edges, where over-tightening can strangulate tissue. The slip knot lets the edges come together with the right pressure, without crushing the skin. Start with an instrument tie. The needle driver is placed between the two suture strands, but for a slip knot, wrap only once, not twice. Then grab the short end and pull in a single, consistent direction to advance the knot. Repeat the same motion and pull in the same direction. Keeping the same direction is what preserves the sliding behavior. Here is the key point. Because it slides, the knot can be tightened too far. The advantage is that it can also be loosened. The knot is adjusted back and forth until the edges are approximated, with no blanching, and the tension looks correct. Once the edge position is exactly where it should be, the slip knot is converted into a square knot so it does not keep sliding. To convert it, place the driver between the strands again, wrap once, and seat the throw flat. The direction is now alternated to create a true square knot rather than a sliding knot. Add another alternating throw, again coming down flat, to lock the knot. Add an additional throw as needed for security, especially with monofilament. That is the finish. The stitch is secure, the tension is controlled, and the skin edges are approximated without being strangulated. Corner stitch. The corner stitch is used for a triangular flap or a corner laceration. The whole point is to secure the tip without strangulating it, because corner tips are the easiest part of a wound to lose. Start on the first side of the wound. Take a bite through the dermis so the needle travels from the skin side down into the subcuticular plane. This creates the first half of the mattress path and sets the height for the corner. Now the critical step. Take the bite through the corner flap, but do not pierce the very tip. Instead, pass the needle underneath the corner in the subcuticular plane, from subcuticular to subcuticular, so the suture captures dermis under the tip without cutting through it. Then move to the opposite wound edge and take the matching bite, again coming from the subcuticular plane back out to skin. The pattern is designed so tension is distributed under the corner rather than concentrated at the apex. Now tie the stitch. Pull smoothly and in line with the wound so the corner settles into place. The goal is just enough tension to seat the tip, not enough to blanch it. Make sure the wound edges are all in the same plane and avoid any inverted edges. Secure the knot with a square knot, keeping the hands low and flat so each throw lays correctly. Alternate throws to keep the knot square and flat. When done correctly, the corner lies flush with the wound edges. The tip is supported from underneath, and the suture is not strangling the apex. That is one corner stitch. Vertical mattress stitch. This is a great pattern when the wound edges need help averting, or when there is moderate tension and a simple interrupted is not quite enough. Setup is the same. Needle driver in the dominant hand and forceps in the other. The driver controls the needle. The forceps gently evert and stabilize the dermal edge. Start with the first, deeper bite, often described as the far pass. Evert the first edge, then enter at about 90 degrees and drive the needle deep enough to capture strong dermis. Follow the curve of the needle through the wound and out on the opposite side. Forceps should control the tissue, but avoid grabbing the very tip of the needle. Now the needle is repositioned for the second, more superficial bite, the near pass. This is the part that creates eversion. On the same side, take a very superficial bite near the wound edge, just enough to capture dermis at the edge of the skin. Then, mirror that superficial bite on the opposite side. These two shallow bites should be symmetric in depth and distance from the cut edge. Make sure the throws stay in a line perpendicular to the wound. If the throws wander, the wound edges will approximate off-center. The suture needle and the suture tail should end up on the same side of the wound. Now the stitch is tied. Maintain alignment and set tension gradually. The first throw is a surgeon's knot, wrapped twice, to hold tension while the knot is seated. Pull in line with the wound so the edges approximate without strangulation. Then add alternating throws to form a square knot and secure the stitch. Each throw should be seated flat, with even tension on both strands. A vertical mattress can avert aggressively, so stop tightening as soon as the edges are well approximated and gently everted, and avoid blanching. Trim the tails. The finished result should show good edge eversion and strong wound edge support. That is the basic suturing toolkit. Control the needle angle to control edge position. Keep bites symmetric when the edges are symmetric. Use buried dermals to offload tension and hide knots. Protect corner tips by supporting them from underneath. Adjust skin tension with a slip knot before locking it down. And use a vertical mattress when eversion and edge support are needed. If this video was helpful, please like and subscribe for more practical operating room skills. Thank you for watching Ellie Scrubs In.